Welcome to the fourth module in this series, Recognizing when you are about to make a cognitive error. The goal of this module is for learners to recognize when they are about to make a cognitive error. The learning objectives are to explain the concept of metacognition as it applies to cognitive errors, discuss how the ability to recognize when data are not fitting together can prevent diagnostic errors, and to describe a case when a failure in type 1 thinking contributed to a diagnostic error. To recap from Module 1, radiologists use heuristics to make decisions when there is uncertainty, and this approach often helps us arrive at the correct diagnosis. Type 1 thinking is fast, pattern recognition. Failed heuristics or errors in type 1 thinking contribute to cognitive biases and diagnostic errors. Failed heuristics are often predictable and preventable. The first case is an 80-year-old with persistent intermittent gross hematuria on dual anticoagulation therapy. The indication is assessed for malignancy. This is the prior imaging study, and the radiologist reviews this prior to reviewing the current imaging study. He notices that there is hypoenhancement of the right kidney with perinephric stranding and determines that this likely represents pyelonephritis. He then goes to look at the current exam, notices that there are non-enhancing regions in the right kidney, and determines that this likely represents progression of pyelonephritis to a renal abscess. He notices urothelial thickening and enhancement and attributes this to the infectious process. He also notices renal vein thrombosis and attributes this to renal abscess. When he notices that there are new pulmonary nodules in the lung bases, he attributes this to septic emboli. The problem is that this is a case of high-grade infiltrative transitional cell carcinoma. The error was in the initial review of the prior imaging study when the radiologist used pattern recognition to determine that the findings represented pyelonephritis when in fact they represented neoplasm. Confirmation bias led this radiologist to determine that renal vein thrombosis and septic emboli were related to abscess when they were really related to carcinoma. Metacognition is thinking about thinking. This term describes an individual's ability to step back from his or her own thinking, observe it, and recognize opportunities for using thinking strategies to mitigate errors. There are several features of metacognition: awareness of requirements of the learning process, recognition of limitations in memory, ability to appreciate perspective, capacity for self-critique, and ability to select strategies. The next example is a case of a patient who comes into the ER with right lower quadrant pain. The radiologist looks at the examination and determines that the finding in the left-sided image likely represents an abscess. One key aspect of using metacognition in image interpretation is the ability to recognize incongruity, ambiguity, atypical presentations, and instances when data are not fitting together. That's relevant to this case because the patient did not have an elevated white count. If you go on to continue evaluating this case, you see that there is also retroperitoneal adenopathy. Reviewing the case further on the coronal images shows that rather than this being a collection separate from the bowel, it is actually contiguous with a small bowel, and this ended up being small bowel lymphoma, not abscess. The next case is a 67-year-old female with hepatitis C cirrhosis and liver mass. The outside report indication is hepatocellular carcinoma. The outside radiologist determines that this liver lesion represents focal nodular hyperplasia. The radiologist at our institution reinterprets this study and comes to the same conclusion. Note that as you look at the arterial, portal venous, and equilibrium phases at the bottom, this is a lesion with arterial enhancement, washout, and pseudocapsule. FNH are hepatocellular in origin and should have a signal intensity similar to liver parenchyma on T1 weighted images. And you can see on the right-sided image that this lesion is not isointense on T1. In the setting of cirrhosis, HCC are far more common than FNH. And in this case, This was a classic LIRADS5 path-proven hepatocellular carcinoma. Don't call FNH in a cirrhotic liver unless it has every feature of FNH. One of the contributing factors to this error is the radiologist reinterpreting the MRI looked at the prior radiologist's report before reviewing the images. You are far more likely to say the same thing as the prior radiologist when you review imaging in this manner, even if what they said was incorrect. Another example of an error in type 1 thinking. This is a patient with prostate cancer and rising PSA. The radiologist reviewing the CT on the left from August 2014 sees sclerosis in the vertebral body and determines that this likely represents degenerative change and does not find any other evidence of prostate cancer. However, on the follow-up CT from February 2015, you can see that this lesion clearly represents a metastasis. The radiologist did not have coronal and sagittal reconstructions available at the time of interpretation in 2014. But if you take the 5mm axial sections and reconstruct those, you can see that this lesion clearly represents an osseous metastasis. The information that doesn't fit for this patient is that they have a rising PSA and are likely to have a prostate cancer-related lesion somewhere in the abdomen and pelvis. This is a case of a chest x-ray that was performed after line placement. The x-ray from the prior day is shown on the left, and the x-ray after line placement is shown on the right. The radiologist interpreting the study on the right determines that the right upper lobe opacity likely represents atelectasis. The new central line overlies the aorta and may be venous or arterial in location, and there is a new right-sided pleural effusion. The problem is that the line placement was attempted on the right and failed and eventually placed on the left. The fact that there is a new central line, a new mediastinal density, and a new pleural effusion all raise the possibility of mediastinal hematoma, which was the case for this patient. The problem is there was information not available to the interpreting radiologist, so they didn't realize that the central line was attempted on the right. This plain film was also interpreted at the end of a 12-hour overnight call shift. So when the radiologist looked at this and they saw the right upper lobe opacity, they instantly thought atelectasis and didn't consider other possibilities. Another example of an error in type 1 thinking. You can see comparison of right upper lobe atelectasis on the left to mediastinal hematoma on the right. There are other imaging features that differentiate these entities. In the left image of right upper lobe atelectasis, you see that atelectasis goes to the hilum and has a smooth border. On the right, mediastinal hematoma does not go down to the hilum and has a shaggy border because of mass effect. This is an X-ray performed for feeding tube and had a very similar looking chest X-ray performed the prior day for the same indication of feeding tube. The radiologist interpreting this said the feeding tube terminated in the peripyloric region and moved on to the next case. The problem is that there was a second feeding tube placed and it terminated in the right lower quadrant. This is another example of an error in type 1 thinking. To summarize, failed heuristics or errors in type 1 thinking contribute to cognitive biases and diagnostic errors. Failed heuristics are often predictable and preventable. Metacognition describes an individual's ability to step back from her own thinking, observe it, and recognize opportunities for using thinking strategies to mitigate errors. One key aspect of using metacognition and image interpretation that I try to emphasize in this presentation is the ability to recognize incongruity, ambiguity, atypical presentations, and instances when data are not fitting together. As an example, be wary of calling abscess in a patient that does not have an elevated white count. In the next module, we will discuss how to use prior imaging to reduce errors. In the meantime, try to identify a case you have interpreted when a failure in type 1 thinking contributed to a diagnostic error.